Hi, this is Laura Kaiser. I'll be presenting today on lower extremity venous disease, which is LEVD. It's one in the series of 3 presentations on lower extremity disease. We covered lower extremity neuropathic disease. Today we'll cover lower extremity venous disease. And the next presentation will be on lower extremity arterial disease. This chart shows vascular insufficiencies and some of the differences between arterial and venous. Usually our arterial ulcers are closer to the toes, the foot, or the ankle, and then the venous ulcers are kind of in the medial gaiter region, like around the calf. The edges of the arterial ulcer are punched out and well defined. It almost looks like a cookie cutter punched out area, where the venous are sloping and gradual. In the arterial ulcer, the wound bed is covered with slough and necrotic tissue. Remember, this is arterial insufficiency, so you're not getting the blood flow, and that's why you have the necrotic tissue. Where a venous ulcer is usually covered with slough, but they do get blood flow. The problem is the blood doesn't go back up. Arterial ulcers are usually smaller, while venous are very large. Venous drain a lot, and you have that weeping serous drainage constantly, where the arterial ulcers doesn't drain very much. Arterial ulcers are much more painful than venous ulcers. Venous can be painful, but usually are not quite as bad as the arterial. And they both require a vascular consult. There's things that can be done vascular for venous as well as arterial. Here's a picture of the venous circulation from the front and the back. If you look in the groin, and remember, if a patient sits for long periods, a truck driver, a desk worker, sits for long periods, you kind of cut off the circulation, not only down but also up, the venous circulation, and that makes the blood pool in the leg, and that kind of creates weak vessels and weak valves, and that adds to venous disease. You look at in the anterior portion, you see in the groin area, and then in the posterior you see behind the knee, and that's part of the problem with patients with venous insufficiency. The WOCN Society puts out a quick reference guide, and it goes through all the different lower extremity, the venous, arterial, and the neuropathic, and it's available through the website. Here's a picture of lower extremity arterial ulcer. You see the punched out area. It's slough, could be eschar, and if you try to go in there and clean that up, the patient has a lot of pain with that. If you also look around the ulcer, you don't see any hair. You see the patient's skin is kind of shiny. Doesn't look like a lot of swelling because they don't really get a lot of circulation down there. Some of the diseases that contribute to arterial ulcers are cardiovascular disease, vascular procedures that they may have, sickle cell anemia, obesity, and smoking. Now here is the venous ulcer. This is lower extremity venous disease, and we call it a venous stasis ulcer. The diabetic foot ulcer is the DFU, and the venous stasis ulcer is the VSU. Some of the associated diagnoses for the venous disease patients are congestive heart failure, lymphedema, orthopedic procedures, and advanced age. Chronic venous insufficiency, known as CVI, happens when the venous wall or the valves don't work effectively, and they don't push the blood back up. The valves become damaged, and they allow the blood to leak backwards. So you really don't get, the arteries bring the blood down, but the veins are supposed to bring it back up. And in a healthy body, they do. But in someone with venous insufficiency, some of it comes back up, but some of it goes back down. So the calf muscles are very important in venous return. So when these calf muscles no longer contract like they're supposed to, then the blood is not pushed forward, because that's what's needed to squeeze the veins and push the blood back up to the heart. The risk factors for chronic venous insufficiency are DVT. If a patient has had one, they're more at risk for venous insufficiency. A history of varicose veins or a family history. Obesity, pregnancy, inactivity, extended periods of standing or sitting, like truck drivers or secretaries or nurses or restaurant workers, or the list goes on, just about everything. Females have an increased tendency, smoking, and if you're over 50 years old. So who does it affect? About 40% of the American population. It happens more frequently in patients over 50 or people over 50. Women are more affected than men. So that kind of takes care of almost all of us in the room. Maybe not today, but one day. So what can we do about it? Know the risk factors. Encourage exercise that works the calf muscles. So just when you're sitting or laying, you can just do ankle pumps, and that's going to work the calf muscle. If you have a job that requires long periods of standing, wear light compression. You don't want to get really tight compression unless you have a problem and that's prescribed for you, but you can get light compression. It really helps. If you have a job that you sit for long periods, then get up and walk. Encourage people to get up, take a little walk to the water fountain. And if you smoke, stop smoking, and encourage others to stop smoking. Secondhand smoke causes as much problems as smoking yourself. So be aware of that and use that in your education toward the patient. Here's a good slide on smoking and things that it can cause. And it's not just for diabetics, it's for every arterial. Smoking restricts the blood vessels, causes platelet aggregation, and leads to clot formation. Carbon monoxide binds to the hemoglobin, and it decreases the oxygen needed for circulation, and especially for wound healing if they have a wound. So anyway, just keep promoting non-smoking. The National Guideline Clearinghouse has the best practice for venous ulcer therapy, and the Wound Ostomy Continence Society puts out this guideline for the management of patients with the lower extremity venous disease. Compression therapy is the gold standard, but it must be selected based on the careful assessment of the patient. So remember, compression can cause problems, so you really need to know what you're doing. You need an ABI, which is the ankle brachial index, and we'll talk more about that on the next presentation. But it's very important with any lower extremity ulcer or condition that you do a thorough assessment and make sure that there's vascular circulation. If there's not, you need to have that assessed by referring to the vascular. It's reported that the high compression is more effective than low compression, but like I said, you have to be careful. And don't use the anti-embolism stockings that they get in the hospital. Those are not designed for therapeutic compression, and a lot of patients think they are, that they come home with those and they think, well, I used them in the hospital and I can use them, but that's not a true compression with the graduated compression, which we need for treatment of the lower extremity venous disease. Consider using a multi-layer system that contains an elastic layer. Pro4 is one of those, and those work really well. Use a trial of modified reduced compression bandages for individuals that have mixed arterial and venous, or moderate arterial insufficiency, and this is found out by the ABI. And we'll talk more about the ABI on next, like I said, and I'll show you how to do a quick ABI assessment. And it's only an assessment, and it tells you where to go from there. You may have to refer, and then there's some complications related to diabetic patients that you need to know. So we'll have that on our next presentation. You can also use the intermittent pneumatic compression device. These are good for patients who are immobile or who need higher levels of compression than we can get with the wraps or the stockings, or patients who have not responded to the stockings or wraps. And I have a slide at the end of the presentation to show you some of the pneumatic compression devices on the market. How can we prevent venous ulcers and the recurrence? Remember, this is a lifelong process, so we have to encourage our patients to undertake a program of physical activity to strengthen the calf muscle, increase the ankle range of motion, because that's where we get the calf muscle back in shape to do what it's supposed to do. So these patients may benefit from physical therapy. Educate the patients that these compression stockings or wraps or bandages or devices, you have to do them every day if you don't want to have the venous edema or the venous leg ulcer. So these patients that think that we can treat their leg once a month, they can use their device, or they don't have to wear their stockings every day, well, we have to let them know that this is what happens when you don't. All patients with lower extremity wounds need to be screened for arterial disease. We can use a Doppler measurement of the ankle brachial index, and it's real important that you know how to do the ankle brachial index as well as apply the compression stockings or the wraps or the bandages. Educate the individuals with normal arterial flow to use the strongest compression that they can tolerate. They always say it's too tight. Well, it's supposed to be tight. So you have to education and train staff to know what the patient needs. And compression stockings can cause problems. It can cause pressure, especially in the anterior area of the ankle. It can cause pressure to the heels. It can cause damage. So education is really important, and continuous assessment. Low compression may be helpful for individuals with lower extremity venous disease and the lipodermatosclerosis. And you'll see a picture of that. It's also, low compression may be good for patients who can't tolerate or apply the compression garments. A little bit of compression is better than none. Or they may not be able to afford the cost of the higher compression garments like the pump. These things are very expensive, and they're not always covered by Medicare. Always have your compression stockings fitted by trained personnel. You can send them to a DME company. Hanger here in Lafayette, the VA for veterans, they have a prosthetist who comes from Alexandria and fits the patient. So if you have a VA patient and you think they need something, you can always call their primary care provider at the VA and ask for them to have the patient fitted for stockings. Always have your bandages and wraps applied by skilled personnel. If you're going to get the family to do the compression wraps, it's real important that you teach them and then have them do a return demonstration, because compression wraps done wrong can hurt a patient. Excuse me. You should closely supervise and monitor the compression for individuals with the mixed disease, especially if their ABI is not 1.0. And always check intermittently what the ABI is, because, you know, anything can happen. Patients have to be assessed continuously. Consider vein surgery, which is sometimes they can do a venous ligation especially if the ulcer's been there a long time and it just won't heal no matter what you do. Sometimes it just pools under that site, and that keeps the ulcer from healing. So you want to refer to vascular for that. And make sure the patient is educated about the necessity of wearing the compression for the rest of their life, elevating their legs, managing their weight, doing their exercises. Avoid trauma, because any trauma to the leg is going to be a traumatic wound, but it's going to become a venous stasis ulcer if it doesn't heal in the normal time. Seek early intervention. That kind of goes for us nurses. And first sign of swelling, redness, or abnormal sensations in your skin, talk to your doctor or your healthcare provider about options that, you may need to take some type of medication. But everybody going out into the workforce in their 20s should really consider a minimal compression stocking, and it would save a lot of problems, especially if you have a family history. If you do smoke, try to stop. If you're a woman, you can't really change that. You can't change your age, but you can do some preventive things to make sure that you age healthy. Continue your patient education and follow-up. They have to wear their compression for a lifetime. They have to quit smoking. They need to exercise. Avoid trauma and leg crossing. Some patients love to cross their legs. I love to cross my legs, but I know that it blocks the circulation behind the knee and kind of causes the blood to pool. So long after many years of doing that, you end up with problems. Talk to them about weight management and nutrition. And they should be assessed regularly by the healthcare provider. See if they're following the recommendations. What are their functional abilities and activities? If that's declined and they're a patient in home health, maybe we need to get in OT or PT. Assess the patient for depression, because these ulcers are very depressing. These patients are not invited to go somewhere because their legs are always draining. They stay home a lot. Sometimes they don't even get to stay in their own bedroom. They have to move from their regular bedroom. They may be married and now staying in a different room because these ulcers have an odor. The dressings are continuously soaked. And also, they like to save their dressings, so make sure that they can save them, and the parts that they can save are usually the ACE wrap. Make sure they can wash them, but don't dry them. Hang them out to dry, and if they're not good, just throw them away. I know our patients hate to throw anything away, but they're not effective if they've lost their stretch. So will my wound ever heal? Wound care is the same. We need to look at all the factors that affect wound healing, their age. We can't really change. Nutrition, we can help them with education. Just because a patient is overweight doesn't mean he's not malnutrition. Looking at the patient really won't tell you. Blood work and looking at what they eat. If their doctor has done some blood work, hopefully we can get a copy of that and know. Pressure, if they're sitting all day and their legs, they think they're elevating their legs by placing it on their walker, well, they have pressure behind in that little area. You want to distribute the pressure where they don't have high pressure points in one area. Their chronic conditions need to be managed. Are they diabetic? Are they congestive heart failure? That will affect their treatment if they have congestive heart failure, because we can't really compress them. We can't push the fluid back up, because then we'll send them into CHF exacerbation. So we have to be really careful when we're treating these wounds and look at the whole patient. What medications are they on? Do they smoke, or does somebody in the house smoke? Is the wound infected, or is it just nasty, dirty that we need to just clean it up? Or do they really need an antibiotic by mouth? What's their vascular status? When we do in the ABI, if they're diabetic, we're going to get a false elevated. So really, if they're diabetic, ABIs can tell you some things, but can't really depend on it with a diabetic because of the veins are not compressed as easily, so you're not getting a true reading. So these patients really need to send them to vascular if there's any question. So here's a few pictures about that show us patients that have chronic venous insufficiency. You get the leg swelling, and it doesn't just go down every night when you elevate. Skin color and texture changes. We all know those patients who have those hemosiderin staining and the scaly legs. Then they end up with ulcers if they bump their leg and end up with an ulcer, then that chronic venous insufficiency will lead to complications, and they have an ulcer for a long time without the proper treatment. Here's a picture of the hemosiderin staining. It happens when the blood vessels, the red blood cells leak into the tissue, and they kind of stay there, and they make brown or yellow deposits, and I'm sure you've all seen this. This is a pretty good picture of venous stasis dermatitis. If you look at around the ulcer, he's got an ulcer, and probably if we wipe all that, it looks like it might be okay, and this is the only ulcer. So he would need some type of something on this skin to treat that. Here's a true venous stasis ulcer. You see it's kind of sloped edges. It's slough. It will be painful. Not as bad as the arterial, but sometimes we can use the lidocaine mixture to decrease the pain if we really need to scrub that and get rid of the slough. Here are some of the treatment options for venous insufficiency. We have the thigh-high compression stockings. These come from Job's Stockings. That's kind of one of the leaders in one of the more well-known. These are knee-high, but remember, if the patient's not going to use it, we tend to find more compliance issues with the thigh-high. It's really hard to put these stockings on. If you've ever tried to put on a true pair of compression stockings on yourself or on a patient, it's not the easiest thing in the world. And people that don't have full use of their hands, it's pretty hard if they don't have help in their home. The Venous boot is good, but the patient has to be able to walk, because the calf pumping is what works with the Venous boot, and it helps to send the blood back up. So your bedbound patients or your patients who don't walk, Venous boot is not the choice. I like the Venous boot with calamine because it normally dries up the weeping dermatitis. Anyway, the Pro 4 is one of the 4-layer wraps. There's a whole bunch of wraps, 3-layer, 4-layer, light. Pro 4 is really good. Just remember that figure 8 wrap has to be done right, and you want to be trained in doing it before you start doing it. So you have the 4 layers. Sometimes if it's hot, I'll leave off the cotton wrap layer, but right now is a good time to use the 4-layer. These are some aids for putting on the stockings. I've worked with the one on the left and the one on the right. I've never used the Job's gloves, but they say they work really good. The wire basket looking thing on the left, the patient really has to have help, or he has to be pretty good, because you put the stocking on there, and then you put your foot into it, and then you pull it up. And I always worry about patients causing more trauma if they don't use this right. Now the one on the right, I've seen it used, and it's really, really easy. I'm not sure if it's covered by Medicare. I know the VA gives this to their patients. I've ordered it when I was there. So again, if you have a patient that's a veteran that goes to the VA, you can get the primary care doctor there to order it, and they'll show them how to use it as well. There's YouTube videos on applications, really helpful. If you want to go to that, you can just pull it up. This on the right is called the Dolphin Donor. DOFFNDONNER, I believe. Here's the pneumatic compression device that I'm familiar with. It comes from Tactile Medical. The one at the top actually replaces the compression stocking, and it gives a continuous compression all day. This is really good for patients who can't put on the stockings, but they need this. Then you can also set it where an hour in the morning, an hour in the evening, you do the pneumatic compression device where it gives that intermittent therapy. You can set it for different things, and when you write the order, the rep, not the sales rep, but the clinician goes out to see the patient, and it's really good. You can Google this also on their website, ActiTouch Tactile Medical. They have some demonstrations that you can watch. Now the one at the bottom on the leg and the arm, these give a gentle massage. These are really neat. I wish I had a pair of them. These are good because it starts from the toes and it gradually is sequential compression. So I'll get the Tactile Medical guy to come one day and give a demonstration. Part of the problem with these is getting it covered by Medicare. You have to have the right diagnosis and the right everything. The VA covers it if the patient is a veteran, and we just write the order, get the primary care practitioner to write the order, send it to prosthetics. They order it, and then the rep goes out and he measures the patients and gets them started. It really works well. This site will bring you to an algorithm for compression. It's really good, but I was not able to make it come up. So we can go to it now, or you can go to it when you want. I think there's a way you can copy it. It's from the Smith & Nephew website. They have a lot of education where you get free CEUs. So this ends our presentation. Thank you for your attention, and if you have any questions, please feel free to call me or email me, and I'll try to get the answer for you. So have a great day. Thank you.